Good morning. Happy Thursday, all. Welcome to another round of VMR. This time it's an all internal affair, and we will, as is tradition, introduce everybody, but start with the people who are fundamental to making this happen. And I feel like we have a regular now in the Thursday 6 a.m. scribing slot, and that is none other than the one and only student Dr. Sohail Patel, soon to be Dr. Sohail Patel. So, do you want to say hi and give us an update on life?
Good morning, everyone. From here, from San Francisco Bay Area. I think it's still dark outside. It's getting darker as we go now.
Mhm.
Changing season, which is really nice because that means that the holidays are coming up. But good to see you all. Really excited for this case.
Do you have a favorite holiday, Sohail?
I have to say December because
Yeah.
uh, the Christmas season, I think it's my favorite. It's
It,
always been my favorite holiday
yeah.
since a child.
Same. Yeah, I mean, it's hard. It would be gifts galore on Christmas Day, and so as a child programmed with that, it's hard to ever shake that or lose that. Scribing today, is Elena all the way across an ocean from Sohail. Elena, what's new in your life?
Hi everyone, it's great to see you. I'm super excited for today's discussion and case from AMK. It's getting autumn in Germany, and it's my favorite season, so that's really great. And I have finished the last part of my journey in med school, pretty much. I
Hmm.
only have to do my final exam at the end of this year, so I'm super excited to get my brain working in internal medicine again because I've been in anesthesia for a few months now, and so that's really great. It's awesome to see you all.
What is your favorite part about autumn in Germany?
Um, I think for a long time I didn't know if I prefer spring or autumn,
Yeah.
but I think it's really the change when you notice that it still feels like summer, but it's not that warm anymore. And yeah, I really like that switch.
I love that. That sounds amazing. Well, you did mention VMR legend AMK. For those of you who are relatively new to VMR, you may not have bumped into to AMK. Gosh, I think since the very inception of VMR, we've been lucky enough to learn alongside and learn from AMK. And so I'll pass the mic to you to say hi and give us an update on how things are going for you.
Hello, everyone. I am so excited. I was just talking and I was like, it's been too long since I've presented a case. So excited to get to do so. And I was looking at the chat, and there are so many amazing clinical reasoners here. So I'm excited to hear and read all your thoughts today. And I'm doing well. I told the group beforehand, just got back from a run. So I like scrambled and everything to get ready. But this is definitely worth presenting at. So.
Well, I hope the endorphins are kicking in. There's nothing more fun than thinking about medicine right after a run for me. I absolutely love it. And speaking of astute clinical reasoners, we have our first time case discussant in Hee Moon, and I've been so excited for today because there have been very few people in the CP solvers world who have uplifted the space just like Hee Moon does. Um, I remember several months ago just seeing her consistently over and over and over on VMR and just bringing so much kindness and so much love for people in medicine. And it's a long time coming to have Moon be in the way we celebrate things here, which is to co-discuss medicine because her impact in our space has been incredible. And I think it's been most recently captured by her joining the Tuesday recap leadership, which she'll be doing going forward. But we're very, very grateful for you. You have a lot of huge fans in the crowd and excited to co-discuss with you. I know the nerves are high, but with AMK and the case presenter realm, I'm sure you'll cruise on. But I'll hand the mic to you to say hello, share with us how things are going, and then we'll jump right in.
Yes, hi, this is Hee Moon. I'm IMG from Korea. It's just such an honor to be able to discuss with my amazing teacher, Ravi. Ever since joining the CP Solver, I have looked forward to like each day, like because I'm grateful to every member for sharing their wisdom and motivation to help me to improve. So I'm so grateful. Yeah, I'm just wishing the best for match season. So yes, I'm really excited for this case.
Amazing. All right, AMK, the anticipated wait is over. Let's rock and roll.
Okay, and this is a case of a 60-year-old male with shortness of breath and orthopnea. Let me know if you want to stop here to discuss thoughts or get a little bit more HPI.
Anytime you give us the chance to reflect on your case, I think we'll take it. Yeah, Heemoon, what happened to your mind when you heard those three pieces of information? 60, I think, shortness of breath and orthopnea.
Yeah, so I think the dyspnea will be like pulmonary and also cardiac and metabolic. But orthopnea is like shortness of breath when life which is more severe than PND. So I'm considering about the person who's having heart failure, like fluid buildup in the lungs, and maybe left side heart failure or a pericardial effusion or COPD or sleep apnea. And also you mentioned about obesity last time and diaphragmatic weakness. Those can be a cause of orthopnea. So yeah, so I would like to hear whether this person is having all like a heart failure or like a history of COPD or also like anemia and anxiety or like neuromuscular weakness can also the cause of the dyspnea. So I'd like to do see more history of the person, or also smoking history, and also whether the person is using some kind of a medication like cocaine. And I want to see during the physical exam, I want to see edema or JVP, hepatomegaly, ascites. Yeah.
That was absolutely superb. You started off by starting with shortness of breath and laying out a thorough schema for that, heart, lungs, and other. And then you use the orthopnea as a clue to what the shortness of breath might be. And Heemoon, isn't it incredible when you just take a moment and think about what orthopnea means? It fundamentally means that a patient can make themselves more short of breath or less short of breath with the way they position their body. And I find that so absolutely intriguing that the way you are positioned influences how you feel with regard to such a fundamental thing that is breathing. And I think it's really, really important for us, I think, to try to translate and make sure that when a patient says they have orthopnea, that you translate that into watching them do the same. And I've had several instances where patients are equivocal about their orthopnea. They're not really sure if it's worse or they're a little bit on the fence about it. So I am always try to have a little bit of a caveat to say, oh, is this orthopnea? How accurate does it line up to what we perceive orthopnea to be? But fundamentally, as you said, when there is a positional relationship to shortness of breath, it really comes down to the two things that are influenced by position: venous return and diaphragmatic function. When you lie down, you make your diaphragm at a significant disadvantage because now the stomach and the gastrointestinal contents are in the way, as opposed to when the patient is standing up, where gravity helps move those things away from the diaphragm, making it easier for it to move. So diaphragmatic dysfunction may be more prominent to the patient when they lie down. But that is much less common than the fact that when you lie down, you bring a whole lot of volume back to your heart by gravity's effect of pulling venous blood back into your heart. And if your heart's not healthy enough to tolerate that fluid bolus, your heart will feel it. And so I think those are the two spaces that we're probably going to prioritize. All right, AMK, what do you have in store?
Amazing discussion already. So on further history, felt really well. In fact, was able to walk several miles at an outdoor event up to 2 months ago. And then 2 nights ago, felt like he suddenly felt profoundly short of breath prior to bed. That lasted about 20 minutes. And then the next day, felt like really could not get a deep breath in and only felt like was getting about 1/10 of each breath. He feels that breathing is better with upright and worse with supine, to the point where he started sleeping in a recliner the past few nights because the shortness of breath felt so bad. Noted a little bit of swelling over the past few months in the lower extremities. Weight has been stable. The swelling is generally worse in the summer and better in the morning, worse after standing on the legs. No fevers or chills, no eye weakness or double vision, no dysphagia or feeling like food gets stuck, no arm or leg weakness, no masses in the neck or neck enlargement, no known sleep apnea, and then no worsening abdominal distension. Um, has not had any sort of abdominal or thoracic surgery in the past. Only exposure was works in a car shop and did 2 days ago note a drop of oil in the mouth, but wasn't really sure if that had anything to do with it. But otherwise, no other toxins. And then maybe there's some mold in the house, but feels like it's mild. No foreign travel or unusual exposures, no history of tuberculosis or incarceration. And then only past medical history is hypertension, for which he takes lisinopril 20 milligrams with and has been controlled. No history of diabetes or CAD. And then has a past 30-pack year smoking history, but quit 10 years prior. Drinks 1 to 2 beers per week. No other substance use or no other OTCs. No significant family history of coronary artery disease, heart failure, early death, or neuromuscular conditions or cancer. And with that, I'll let y'all discuss more.
Yeah, if people didn't know you AMK, they now know just how incredible of a case presenter you are. I mean, the way you're choosing to share this information with us is just so enlightening, and I think sets Heemoon up for a really thoughtful conversation. Heemoon, because there's so many aspects of this case, maybe we can just take it step by step, and maybe I'll just ask you to shed light on the first part of orthopnea, which is, do you believe the patient's orthopnea maps on to how you think about orthopnea, meaning that is this pseudo orthopnea, or do you believe that based on what you heard from the HPI that there is true pathophysiological entities of orthopnea here? What do you think?
I think it's the truth because the when lying down it gets worse, and also there is some swelling. And yeah, weight is stable. Like sometimes, peripheral edema can cause weight could be a little bit increased, but yeah, I mean, it's kind of, if it is mild, it's not going to cause that much. But yeah, I think because yeah, she mentioned that it worsened with the spine, and some yeah, like breathing is better with upright and worse spine, and extremity edema could, pointing to the true orthopnea.
Absolutely superb. Yeah, I think the richness of the history here, the extreme amount of detail that the patient provides, and the projected confidence of the marked difference between positions is very, very telling. And in real life, you'll see a lot of patients be like, I'm not really sure, or I can't quite tell. And the orthopnea comes not from the patient, but comes from us asking the patient if they have orthopnea. This seems like a circumstance where the patient is leading with it and emphasizing it. And so I agree with you. I think I'm much more inclined to think that the orthopnea is real. And so from the very beginning, when you outlined your two differential diagnoses, either this is a heart issue or a diaphragm issue. And so where are you leaning towards? What's your analysis of what evidence is suggesting a heart issue and what evidence is suggesting a diaphragm issue? What do you think?
I think that heart failure is, like, I like to go with heart failure more because it's heart failure can cause, when you are laying down, it can cause orthopnea. And for diaphragm weakness, it's breathing will be reduced with a flat, but there's no weakness, or I'm not sure about that, but yeah. So diaphragm willingness is not really pointing out. I don't think I see it. Maybe I'm not clear with that, but yeah. What do you think?
Oh, I think this is a fantastic opportunity for us to talk about the law of proportionality. Your argument against the diaphragm is very strong in that you're saying so far we haven't examined the patient, but there's no evidence of neuromuscular weakness anywhere else, which by definition reduces the probability of diaphragmatic weakness. No doubt about that. If you had heard in contrast from AMK that the patient had diplopia dysphagia, you would run to that, right? So the absence of extra diaphragmatic clues certainly reduces the probability of diaphragmatic weakness. And the probability of diaphragmatic weakness is even more reduced based on base rate. It's so much less common than heart failure. So there are many, many holes in the diaphragmatic hypothesis. The first is that it's uncommon. The second is there is no extra diaphragmatic weakness. And whenever you hear shortness of breath and orthopnea, you have to run towards congestive heart failure. And I think that whenever you hear swelling in the legs, the hypothesis of congestive heart failure gets reinforced even further. However, there's a little bit of a disconnect between the lower extremity edema and the orthopnea. And I think that disconnect is twofold. The first is that the lower extremity edema seems to have a much different time course than the orthopnea, right? AMK was telling us that it is a long-standing issue that fluctuates based on the season. And the other disconnect, I think, is the law of proportionality. So Himun, let's just have that as a conversation together. In the patients that you've seen or heard about or read about who present with heart failure, what would you estimate is their average time course of symptoms? Meaning, do patients with heart failure usually present hours, days, weeks, or months, as far as you know?
Well, could be if it is a chronic, it's going to be months and
Yeah.
long, right? Yeah, and if it is acute, I mean, it could be certain like short days, but yeah.
Yeah, you're very right. There's a very wide spectrum of presentation of heart failure. What is happening in heart failure is there is a reduction in cardiac output that first manifests as a reduction in patients' exercise capacity. They can't walk as much. And only after the cardiac output has reduced significantly does the patient start to experience passive congestion. Our ability to increase our cardiac output, just like AMK probably quadrupled or tripled her cardiac output on the run. And so patients who have heart failure, when they're starting to experience disease, can compensate and increase their cardiac output only when all their mechanisms are gone, they start to have a traffic jam. So most people with congestive heart failure history, if you really, really talk to them, they'll tell you that for weeks, if not months, they've had a slow reduction in their exercise capacity as their cardiac output is dropping, and then a week or two of passive congestion, and then they come to clinical attention. So when a patient develops symptoms compatible with heart failure abruptly, as this patient did 2 nights ago, you know what that means, Himun? That means that this patient lost all of his cardiac output on the order of 48 hours, if the heart is the correct hypothesis. And so how sick do you imagine someone to be if they lost all their cardiac output in 48 hours? What do you think? Oh, you're muted.
Very terrible, like having a cardiogenic shock or
Yeah, right.
arrhythmia or yeah,
Right.
syncope or yeah.
Yeah, exactly. And look at his story. He developed orthopnea 2 days ago, and his only clue is that he has a little bit of swelling in his legs. He has no syncope, pre-syncope, no forward symptoms. So if I were to summarize our thoughts, orthopnea, base rate suggests cardiac disease. Here, the rapid development of orthopnea, along with the absence of other clues that suggest the rapid development of heart failure, namely forward flow symptoms, would push me earlier on to move past the heart hypotheses and focus on the diaphragm. Now, I'm not saying that I would move past them and skip them, but I would now simultaneously be open to an unusual presentation of the heart and an unusual presentation of the diaphragm at the same time. Because Heemun, neither hypothesis, heart or diaphragm, is fully lined up. And the holes in the diaphragm it's uncommon, and there are no extra diaphragmatic weakness, but there are just as many holes in the heart failure hypothesis, and that has to do with the law of proportionality. The orthopnea is way out of proportion to other cardiac clues, forcing us to evaluate each of these hypotheses in parallel. So maybe we can just practice for the exam. Any tips or tricks you have, Heemun, if you're seeing this patient next year as a highly successfully matched intern, what might you be looking for on exam to help you either way? What do you think you might do?
Well, I guess just to for the physical exam, do you mean, or
Yes. Sorry,
yeah,
for the physical exam. Yeah.
yeah, for physical exam, I just have to rule out everything,
Yeah.
whether it's so JVD and heart murmur and everything, but also diaphragmic you said diaphragmic weakness. So whether is there any way to see reducing breathing respiratory rate to measure? I'm not sure. Like,
Yeah, very, very good. I'm glad that's on your mind. And if you were in real life, you know all the heart failure maneuvers, and then you would Google, how do I get diaphragmatic clues on exam? I think the most powerful clues for diaphragmatic disease on exam are extra diaphragmatic weakness, which you would try to do. So you do a full neuro exam. But there are two key things that you can do. The most simple at the bedside is to look for paradoxical abdominal breathing. When the diaphragm is functioning normally, when you take a deep breath in, the diaphragm moves downwards, pushing the abdominal wall outwards. Take a deep breath in, your diaphragm moves down and pushes your belly outward. When you take a deep breath out, diaphragm moves up and the belly gets sucked in. Try it right now on your own belly. Put your hands on your belly, and hopefully none of you will be diagnosed with diaphragmatic weakness as we do this. Take a deep breath in. Belly goes out. Take a deep breath in. Belly goes in. Patients with severe diaphragmatic weakness have paradoxical abdominal movements, where because of the weakness of the diaphragm, the exact opposite happens. When they take a deep breath in, their stomach gets sucked in. And when they take a deep breath out, their stomach goes out. The reason for that is the intercostal muscles. When the diaphragm is weak, the intercostal muscles are the primary inspiratory mechanism. And when they go out with inspiration, they suck the abdominal wall in, and vice versa. When they collapse, they force the abdominal wall out. So looking for paradoxical abdominal movements is going to be really key here, though it's actually only a feature of advanced disease. So that'll be one thing that you and I can do if we were seeing this patient in real life together. But there's another really interesting test called the sniff test. Have you ever heard of that before?
yes, I just Googled it.
Yeah, oh yeah, tell us. What did you learn?
Yeah, ask the patient to take a quick, sharp breath and snip, normally the diaphragm moves downward and abdomen proves, but with the diaphragm weakness, you may observe paradoxical inward movement above the abdomen.
Amazing. Spoken like a pro. So long story short, there are many maneuvers to test the diaphragm. The simple one is the bedside maneuver, which we just talked about. But you can also do the mean inspiratory force or mean inspiratory pressure, where respiratory therapy gives the patient a device that they have to be able to surround their lips on, and ask them to take a deep breath in, and how much pressure they're able to generate, and gives us a sense of how strong their diaphragm is. There's a really cool bedside correlate to that, which is without the respiratory therapist, you can ask your patient to take a deep breath in and count as much as you can. 1, 2, 3, 4, 5, all the way until they are able to get the breath out as slowly as possible. And the longer you're able to do that, the healthier your diaphragm is. And if you're not able to do that for more than up to 20 or 30, that suggests your diaphragm is weak. So, Hee-moon, I think we have a very, very intriguing case here where, in addition to the usual heart failure exam, we should probably assess for diaphragmatic strength on the physical exam with paradoxical abdominal movements, and to assess either accurately through respiratory therapy or inaccurately through the counting test how strong the diaphragm is. Maybe we can start to see if this case goes towards the heart or the diaphragm, and then we can come back to see how the medical history helps us. But right now, I think we really have to figure out, are we solving a heart problem or a diaphragm problem? All right, AMK, Mike, to you. Very, very intrigued.
Yeah, amazing discussion. So on vital signs, the temperature was 36.6, afebrile, heart rate was between 70s and 90s. Respiratory rate was 16 when upright. And blood pressure was between systolics in the 130 through 160s, diastolics through the 70s through 90s. And the oxygen saturation when upright was 96% on ambient air, BMI of 40. When I saw the patient was sitting in a chair because more comfortable. Extraocular movements were intact. There was no nystagmus, no weakness on sustained upgaze, no enlarged lymph nodes in the neck or thyroid megaly or masses felt. The heart was regular rate without murmurs, unable to see the JVP due to just the neck and how anatomy. The on lung exam, there was diminished breath sounds in the like bilaterally, but worse on the right side. Did not hear any crackles. The abdomen was non-tender, no significant distension. There was 3+ pitting edema around the ankles and 1+ pitting edema around the tibia. On neuro, there was no focal weakness, able to move arms and legs, had preserved patellar deep tendon reflexes, really strong hand grip, sensation intact. And then otherwise good muscle mass. And then the reason why we're actually called for admission is earlier, which I'll get to the results later, but the ED had ordered a CTA, and when the patient went to lay flat for it, actually got like really diaphoretic, short of breath, kind of turned blue. They didn't have an oxygen monitor in the room, but like put on a non-rebreather, got back quickly to the ED, was 93% at that point, but then was able to get stabilized, set up right, and better now off oxygen. But when you talk to the patient, he's like, I thought I was gonna die. And that I'll leave things there for discussion.
Oh my God, what a dramatic piece of information. That sounds absolutely terrifying for the patient. Yeah, so Hee-moon, what happened to your thinking there? Heart, diaphragm, what are the pros and cons for each? What crossed your mind?
Well, so diaphragmic weakness is, since you mentioned, I think I'm kind of close to that because there was unable to see the JBP, but still there is a 3 pitting edema, and then so I cannot really like rule out heart failures, and the diminished breath sounds. Breath sounds could be, due to like some atelectasis or like some pleural effusion, or so I don't know. I mean, still too is possible. Phrenic, nerve injury or dysfunction by paralysis, and who's atelectasis or yeah, so I'm still thinking to both, but yeah, give us wisdom.
Your analysis is absolutely superb. I think you should be very proud of it. And the reason I'm very proud of it is because in VMR, it's very tempting to try to guess what the answer is, but your authentic response that it could be both is superb. And I agree with you. If we're being balanced, the edema, 3+ edema anywhere should really make you think heart failure. Really should. And I think that pushes us certainly that way. Your analysis of the breath sounds is superb. If they're pleural effusions, that supports heart failure. If there's not pleural effusions and it's atelectasis, that supports diaphragmatic dysfunction. So there's a tension here. So we can talk about two abnormalities, the positional component to it, which we heard from AMK, which is when he's sitting up, he looks great. When he lies down for the scanner, he looks like he needs to be intubated. So I'm curious what you make of the dramatic degree of orthopnea. Does that help you go one way or the other, given how sick he becomes when he lies flat? Oh, sorry, you're
Yeah,
yeah.
yeah.
Okay.
So orthopnea, if it gets severe, I think I will go with a diaphragmatic uh, paralysis. Is more close to that. Um, yeah, but I
Yeah.
think I need more wisdom. Why is it
Right.
because of that? Yeah.
Yeah, I think that the amount of venous return with lying flat is not sufficient to compromise the heart to this degree. When we say orthopnea, what we're saying is the patient's probably getting a fluid bolus of anywhere between 250 cc's to 750 cc's. And if the heart is so sick that 250 cc's or 500 cc's makes it get that much sicker, then at baseline, the heart should be very, very sick. So if you tell me you have a patient with heart failure who almost died after they got a 500 cc bolus, then when they sit up, they're still almost at death's door. But if you tell me that the patient sits up and goes back to being able to have a comfortable conversation, that's not compatible. The heart's not sick enough to have done that in the first place. Does that make sense? So yeah, it could have been the heart. We've all done 500 cc's, and I've done it and made the patient much worse. But when you take off that 500 cc's, they're still not great. So the degree of orthopnea from normalcy to almost death is very concerning for diaphragmatic dysfunction. And there's one clue in the vital signs as to why the patient may be feeling diaphragmatic weakness more than other people. And it's not the temperature, it's not the heart rate, it's not the blood pressure, it's not the respiratory rate, it's the BMI. So this is a tough question, Himun, but I'm curious, how do you think the patient's BMI might be influencing how symptomatic he is from a possible diaphragmatic weakness?
Yes, so the obesity can increase abdominal pressure, right? So can really make orthopnea worse, in addition to diaphragmatic paralysis.
Absolutely superb. Yeah, I think that if you think about what the diaphragm has to do, it has to move the lungs against the chest wall and has to move the lungs against the abdominal wall. And the heavier the chest and abdominal wall are, the harder the time the diaphragm is going to have. And so I think the question really now is, are there any signs of vascular congestion on point of care ultrasound, chest x-ray, BNP? The BNP here will be limited because of the patient's BMI, as the BNP is cleared by adipocytes and other mechanisms that reduce the BNP. But I think the case for diaphragmatic weakness with the delta between positions is very high. And so I would probably proceed to mean inspiratory pressure force. And I think the question on my mind, to be honest, is this actually a disease that is 2 days old? Or is this the tip of the iceberg? And this is a subacute progressive disease that has risen to the surface more abruptly. In other words, is this patient having the equivalent of aortic stenosis, where the problem has been going on for decades, but they finally present with a syncope, not because the disease developed abruptly, but because of the compensatory mechanisms to protect the patient from a presentation were abruptly depleted. Was he walking towards the edge of a cliff for the last few months or years and then came very close to the edge? Or did this really begin very abruptly? And I think his BMI suggests that he may be manifesting more severely than other people, and has me wondering whether this has actually been brewing for some time. But I think, yeah, we have a lot to think about, and I'll hand the mic to AMK to tell us more. Very, very intriguing.
Yeah. Yeah, awesome discussion. I will say it felt very clear through discussion that this was very, very new. Was able to walk miles and miles before and lift heavy objects. So this is a few day process. So on further history or on further labs, the lab showed a CBC of 9.4 with a completely normal differential, a hemoglobin of 13, and platelets of 450. The sodium was 141, the potassium was 4.4, the chloride was 107, bicarbonate was 29, BUN 13, creatinine 0.98, glucose 102, normal hepatic function panel, and calcium was also normal. High sensitivity troponin was 7 with a delta of 0. BMP was 15. D-dimer was 1,800. And then VBG showed a pH of 7.37 and a CO2 of 54. Urinalysis showed a SPECT-GRAV of 1.2. And then it was otherwise unremarkable. No other cells. The CRP was 8. The TSH was normal. The CK was 244. The hemoglobin A1C was 5.5. And then COVID, RSV, and influenza was negative. Chest X-ray showed mild cephalization of the pulmonary vasculature per the read. And then CTA showed no signs of PE, no pericardial effusion, and no significant coronary calcifications or pericardial calcifications. In the ED, they had actually gotten an echocardiogram showing a normal EF with exaggerated ventricular septal motion with respiration. It's a differential including constrictive disease versus obstructive lung disease. And that is all the information you have when you are admitting this patient. You are admitting them at a smaller hospital without subspecialists overnight. It is very late in the day. And then you kind of have to think, like, what do you want to do at this point?
I do not envy your position, AMK. I think that's a very tough place to be, though. I'm jealous that you get to grow your clinical skills in that environment. I think it certainly would be stretching me beyond my comfort zone. But Moon, where are you at? What is your analysis so far?
Yeah, so I think all those lab and BMP is not really indicating heart failure. So we should go for the diaphragmatic paralysis. So I wonder whether this person is able to do any like pulmonary function tests, like short, like to do it, and also like diaphragmatic ultrasound to look at the function of the diaphragm. And yeah, so I think I kind of more close to diaphragmatic paralysis. So we'll do some more exam for those belongs to those tests.
Yeah, no, I agree with you, Heman. I think that the case for heart failure is weakened significantly in many respects. I think the biggest reason it's probably weakened, in my opinion, is that CT scan does not show any evidence of pulmonary edema, which reduces the probability, if not eliminates it, of left-sided disease. And so if this person has heart failure, they have isolated right heart failure. And don't get me wrong, with a BMI of 40, it's very possible that a component of this patient's disease is pulmonary hypertension related to the consequences of obesity, such as OHS or OSA. But you haven't found a dramatic explanation in the heart. And I think I would be really worried about the diaphragm. The fact that the patient's hypercarbic reduces our the fact that the patient's hypercarbic in the context of obesity reduces our ability to confidently interpret that they're having hypoventilation from diaphragmatic weakness. But I think yeah, I would be really, really struggling to figure out how to take care of the patient in the context that AMK described, because I'm with you. I think this patient needs a tremendous amount of subspecialty care. I think a neurologist would probably be of tremendous value add in this circumstance to help us really be confident in our problem representation about isolated diaphragmatic weakness versus diaphragmatic weakness with subtle neurological deficits elsewhere. And I can't tell you the number of times I thought the patient didn't have any extra neurologic clues, and the neurologist comes and they do like a really subtle neuroexam and they pick up something else. So I think that's the key aspect of this case. But I also would love for a pulmonary critical care physician to help us diagnose diaphragmatic dysfunction with their subtle use of point of care ultrasound. I know AMK is an ultrasound enthusiast, so she may have developed the skill to suspect diaphragmatic disease, but I definitely don't have that. So I'll just be honest, like with what I know, I think I would be extremely worried about this patient, especially after AMK just re-emphasized that this disease really began to really affect the patient 2 days ago. So with what I know, and I don't get to practice in this scenario, AMK, I live in a practice in a very resource heavy circumstances. I would probably try to get the patient somewhere else, in a place where they can get those resources. I think that we could be on the verge of a really, really serious issue very soon.
Yeah.
How are you? I'm really curious. How are you thinking
Yeah.
about it? How did you handle that element of it? I'd love to learn from you.
I have a question. Yeah, AMK, I'm sorry. I have a question. For this patient, you mentioned the device like BiPAP can help for this patient.
Yeah, and so I was struggling because we do have more resources during the day and are able to transfer to our kind of other hospital that has all the subspecialists in the world. And so, but because he looked good now, I decided let's have the RT get respiratory mechanics. Let's put on continuous oxygen, train the VBG, and put on BiPAP and really closely monitor overnight. And then, have the pulmonologist see like first thing in the morning and find out if anything happens, go ahead and transfer to our main campus. And so the NIF came back at like -25. And I was like, oh my gosh, but I like went to reevaluate him. And I told the nurse, do not let this patient be supine at all. And with BiPAP actually did really well overnight, felt a million times better in the morning. And then I went ahead and with that also ordered pulmonary function test with the the MIPS and MEPS, and the pulmonary function test showed in FVC within 44% predicted, FEV1 of 43% predicted, with a normal FEV1 to FVC ratio of 99. The total lung capacity was 31%, predicted, and the vital capacity was 37% predicted. The DLCO adjusted was 52% the reference range, and surprisingly, the MIPS and MEPS actually came back normal. But had a really high suspicion. So we'd also ordered a sniff test. It just couldn't be done right away due to circumstances. And I'll show you a picture. It's a fluoroscopic test. So I'll show you a picture of it. Just one moment. Okay. Okay. Let's see. Okay. Okay, can y'all see that?
Oh, and not yet. I think we still see so we'll screen. Oh yeah, there we go. It's coming up now. Yeah.
So, so that is the SNP test. If y'all want to give your thoughts on the further information.
I'm not sure, Himun, if you had experience. I've actually have never seen a sniff test or interpreted it. I'm curious if you have, Himun.
I really didn't have. I just the pulmonary function test was showing the restrictive pattern. I was for sure, but the chest X-ray to access diaphragm motion, paradoxical movement, elevation of diaphragm, shows weakness. But I don't know how to interpret in this chest X-ray.
Yeah, AMK. I've read about the sniff test, but I've never interpreted. I'm really curious if you can teach us what you learned in this. Complete knowledge gap for me.
So if you look here, you can see under fluoroscopy, you can see the right diaphragm, but you can't see the left. So it actually showed right diaphragmatic paralysis because, when you inspire, the diaphragm goes down. So interestingly, there was not bilateral paralysis, which again, a little bit concerning, but obviously there was a lot of, a little like kind of odd, but there was a lot of respiratory weakness there. Sorry, I am going to pause my screen now. To get back to the regular meeting, if y'all want to share the regular screen again. And then if y'all want to kind of share your thoughts there, and then I can share the rest of the info. And I will just say an interesting kind of thing to consider is on especially a CTA of the chest. A lot of times you're trying to get an expiratory phase. And so it's not going to be it's not going to be good to evaluate the diaphragm. Because I was talking with radiology, I was like, can we see any diaphragmatic weakness on this? And they just felt like it was not the right test for them.
Yeah, I think thank you for that teaching on the sniff test. I think it makes a lot of sense. The idea being that when you take a deep breath in, the diaphragm should really go down, and when you don't see it go down on the right, that is abnormal. Yeah. So Heman, how are you interpreting the PFTs? You came to a conclusion about the PFTs. Do you mind just going through that again for us?
Yes, so the FVC and FEV is reduced, but the FEV is normal to above, so it's not obstructive, and total lung capacity is decreased, and DLCO too is decreased too, right? Is it AMK?
Yes.
Yeah, so that means a restrictive pattern, and then with the test X-ray elevation of diaphragm will showing the diaphragmatic paralyzed weakness.
Absolutely superb. So what you're saying is that the lungs are essentially very small and cannot fill up with air.
Mm-hmm.
That's why the FVC is low, the FEV1 is low, and the total lung capacity. The lungs are small. When you are trying to figure out why the lungs are small, what you're going to try to distinguish is intrinsic lung disease. There's something wrong with the lungs because they're fibrotic and shrunken, or there's external causes that causes the lung to be small. Either the diaphragm is not expanding, or there's compression from the chest wall. And the compression from the chest wall can be kyphosis or obesity. And so one helpful tool that you already pointed out is to say, is there an intrinsic issue like restrictive lung disease, or is there an extrinsic diaphragmatic or chest wall issue? Is the DLCO. The idea being that if the DLCO is normal, that means the lungs themselves are healthy. And the reason they are not expanded is because the diaphragm or the external chest is not letting them expand. And you came to the conclusion, appropriately so, that when the DLC is low, that suggests intrinsic lung disease. How does that match with the fact that we on CT scan don't see any intrinsic lung disease? And the conclusion to that is to remember that external restriction can cause compression and atelectasis, and the atelectasis can drop the DLCO. So in our textbooks, a DLCO is a great way of distinguishing restrictive lung disease from external restriction. However, there's a flaw. And that flaw is that external restriction can induce atelectasis, which causes a low DLCO. So to summarize, in the face of restrictive PFTs, a normal DLCO prioritizes external disease. A reduced DLCO can map onto fibrotic lung disease or atelectasis induced by external restriction. And I think here, the fact that the imaging is normal and the diaphragm is weak suggests that this is an external restriction with subsequent compression of lungs. So I guess, Heemoon, now we have to think, okay, we found what we were looking for. We found diaphragmatic paralysis. How are you thinking about what you might do next in terms of understanding what the cause is?
Yeah, well, for the management, right? Management wise, right? So MK mentioned about the non-invasive ventilation to assist breathing, and like we have to find out underlying cause. I'm not sure what is underlying cause of this person's diaphragmic, but we have to find out, and then maybe like diaphragmic pacing could be help.
I mean, you're absolutely right. I think initially non-invasive ventilation is going to be key for this patient. I think in terms of the cause, you're right that it's pretty unusual to have isolated diaphragmatic weakness be this severe. But I think with the lack of extra diaphragmatic dysfunction, we're zeroing in on that. And isolated diaphragmatic weakness, especially when unilateral, is often idiopathic and does not have a clear culprit cause. The most sneaky underlying cause is cervical stenosis and compressive cervical disease compressing on the nerve roots C3, C4, or C5. So I think the question will be, does this patient require an MRI of their neck? And does this patient have cervical stenosis? I think the most important thing to address here is something that AMK said, and I just want to emphasize it. It's very unusual for patients with unilateral diaphragmatic weakness to be this sick. Most patients who have symptomatic diaphragmatic weakness have bilateral disease. And so here I suspect that either we're not detecting what is actually left-sided disease, or it's that this patient's BMI is making unilateral disease more symptomatic because of the amount of work the diaphragm has to do to function normally. So I think that's just an aspect of this case for us to reflect on. But I'll hand the mic to you, AMK, to tell us what happened next. Oh, I think you're muted. Sorry.
Oh, sorry. I tried to unmute, but I didn't click aggressively enough, I guess. So did get neurology evaluation, as you mentioned, did get an MRI of the cervical spine that it showed some disc disease, but no cord signal suggesting myelopathy. And then got a full workup, some of which came after. And I'll save one of the labs for later. But B1, B6, B12, copper, zinc, ANA, myositis panel, ENA, SPEP, HIV, hepatitis panel, and vitamin D were all unremarkable. And just for time, I will share this tidbit. Did actually have improvement in the hospital, really improved with non-invasive ventilation. Eventually got discharged with plan for close follow-up, but 10 days after discharge, notices droopy eyelids with the left greater than right and some intermittent blurry vision. And it can get worse when outdoors, no eye pain or injury. It did not notice fluctuation with symptoms and also felt like he really got tired from chewing. And with that, I will let y'all share your final thoughts and then share the final diagnosis.
I wonder myasthenia gravis could be the reason for that. So, the acetylcholine antibody, we should go for it. What do you think, Rabih?
Yeah, I think it's absolutely superb. I agree with you. I think the development of ocular symptoms in this context is very suggestive of neuromuscular junction disease. I think that this goes to show you the value of EMG testing in patients with diaphragmatic dysfunction, because the EMG has a very shrewd ability to help you localize whether this is a muscle issue, a neuromuscular junction issue. And so I think that test is a very powerful one to deploy in your patients who have this kind of behavior. And I think even in the absence of ocular symptoms, you might have been able to suspect neuromuscular junction disorders, though EMGs are very, very hard to get and obtain in the inpatient side. They often, in my hospital, take weeks, if not months. And so I think, yeah, you're right. The development of ocular symptoms really makes neuromuscular junction diseases of significant concern. I'm curious, in addition to myasthenia gravis, which I agree with you is probably the most likely diagnosis here, do you know of any other neuromuscular junction diseases, Heemoon? Would you think of anything else?
Yeah, ALS can also cause that, but it doesn't have an upper or lower motor neuron. Yeah, so yeah, or MS sometimes, multiple sclerosis sometimes cause that too, but it doesn't really carry the symptom of multiple sclerosis. So I was just wondering, did you do like eye peak test, like I put in the eye and it gets better with the patient?
I would say just to keep it brief, because there's so many really possible scenarios here. Whenever you're thinking about neuromuscular junction diseases, myasthenia is the most common cause by far and away. Botulism is the most deadly, and Lambert-Eaton is the most sneaky. And I think whenever you have a 30-pack year smoking history, you have to be open to the possibility that the patient has Lambert-Eaton. And so I think that Lambert-Eaton is actually typically the opposite of myasthenia. It usually presents with autonomic symptoms and leg weakness and hyporeflexia. Here, the patient doesn't have any features of Lambert-Eaton except the fact that he's at risk for it based on the connection with smoking, small cell carcinoma, and Lambert-Eaton as a result. But I agree with you. I think that ocular symptoms in a patient with normal reflexes really makes us worry about myasthenia gravis. But in this patient, I think the EMG would be very illuminating, as the EMG can help you localize to presynaptic diseases like botulism and neuromuscular junction and botulism, or postsynaptic diseases like myasthenia gravis. Yeah. AMK, what did you find?
Yeah, so the acetylcholine receptor antibodies actually came back fluidly positive at 15.4. And these were actually obtained even before the eye symptoms developed, and then was started on treatment for myasthenia gravis. So I thought it was a super interesting case because I just saw on admission, and after I heard about the CT scan and everything, I was like, there's diaphragmatic weakness, and I just don't know why. And which was why I was like asking every question in the book, but it was kind of an odd manifestation of MG with some, lateral phrenic paralysis is and probably some kind of subclinical weakness, which became unmasked by in that setting. So definitely learned a lot, and also want to thank the Razais because of their schema on orthopnea, like diaphragmatic weakness was on my mind from the beginning, and because they had taught me that. So that was really cool.
Oh my God, your shout out to the ALA crew is awesome. I think that's very, very touching. And I think all three of you are actually in the CP Solvers orbits as early residents. And it's crazy just to think about where all three of you are now. That's really, really cool. And I think it's very, very impressive for a busy hospitalist to think about diaphragmatic paralysis from the get-go in a patient like this. Because Himoon, if you are operating in a busy circumstance, you see a high BMI, you see leg swelling, you're like, oh, of course, this is heart failure. I mean, the number of patients who have cardiac consequences of a high BMI is so much. It's a lot of what I have to do. And so the ability to actually see through that and see that this is different is incredible. And I think AMK did it in real life. But I think what is just as impressive is for somebody who hasn't even started intern year to have mentioned it from the word orthopnea. And I really, really commend you for that. And I commend you also for being so authentic in your discussion of not pretending like you knew it was diaphragmatic weakness simply because it was VMR. Your analysis of the exam was so balanced. And then at the end, you're like, no, this is myasthenia. It has to be. It was so, so cool. I think you should be very, very proud. How do you feel now?
Well, I really appreciate it. This case was very, very good. I learned so much. Thank you. And Rabih, this is my first time, but I was very excited, and I'm glad that it ended, nicely. And yeah, and oh well, since AMK mentioned about Reza, I really like to watch Reza's, YouTube, and he always say, "Work hard. You can be smarter, tomorrow than yesterday." So I wanna, mention that. And yeah, thank you so much giving this opportunity to discuss with you.
A pleasure's all mine. We've been waiting so long for AMK's return to VMR. Oh my gosh. We waited too long, AMK, way too long. Thank you both so much. I really, really appreciate it. I owe you both an apology. I actually am already a little bit late for work, so I made Elena the host for this session. I will check out your teaching points at the end. Thank you both so much, and I hope you guys have a great day.
All right. Thank you so much, AMK, for this fantastic case. And I hope we don't have to wait such a long time the next time for you to present a case. Himoon, I'm stumped. This was really awesome, and yeah, I tried to keep it as short as I can. And I think that the part that I like the most about the teaching points that you gave me is that we can always go back to the beginning because you laid out the lens so well that we will always go back to the initial questions that we had. So this conversation is all about orthopnea and what does it mean. So usually we think that what does the patient actually mean by orthopnea? Is it really when they lie down, or is it when they go to bed at night? So is it diurnal or is it positional really? And there's actually two possibilities why you would have more shortness of breath when you lie down. And this is either due to increased venous return, so more preload, especially in the context of LV dysfunction and HFrEF, and less likely to be in the context of diaphragmatic, usually muscular or neuromuscular disease. So we mentioned specific diseases like, as I said, LV dysfunction and HFrEF, but also COPD and asthma can worsen during, like in the night, because the vagal tone increases and bronchoconstriction would get worse. Less likely, as said, is neuromuscular diaphragmatic weakness, and also secondary strain on the diaphragm in the context of OSA or obesity hypoventilation, which was of concern in this patient because of the BMI that they had of 40. So generally, in the absence of like extra diaphragmatic weakness, which the patient didn't have, also negative test findings like paradoxical abdominal breathing, which usually presents in advanced disease, and a negative sniff test, neuromuscular etiologies are usually less likely. We talked a little bit about how HFrEF presents if they are the cause of orthopnea, and usually it is a slow reduction in exercise capacity over weeks or months, and then followed usually by a more acute phase of congestion. Patients will usually have lower extremity edema, pulmonary edema, and maybe even some ascites if it develops more acutely. But this was not really how the patient presented, because it seemed to be a very acute onset, and that's what we usually do not associate with decompensated heart failure. But there can be cardiac causes for hyperacute heart failure, namely ACS, tamponade, and arrhythmia. Yes. So we were really like stuck in this tension when AMK told us that when they got the patient to lie down, that they had like a severe visible shortness of breath and also probable hypoxemia, as we saw the patient like turn blue, like they looked hypoxemic when lying flat. And at this point, Rabih shared with us that even if in advanced HFrEF, the bolus that you get when lying flat shouldn't like make you so bad that it would cause like hypoxemia and that like shortness of breath. It can, but when the patient would get like sit up again, then they wouldn't like get immediately better. So at this point, we were back at venous return versus diaphragmatic, and this clinical finding was actually more along with diaphragmatic disease. So we got a little bit more information from AMK with the echo, with the CT chest, and we saw that there was no LV dysfunction, and there was also like no pulmonary edema. And so with the severe aggravation when lying flat, again, a diaphragmatic disorder at this point was most likely. Himun reminded me how to read PFTs at this point because I think I forgot. And they clearly showed restriction with the normative no index. So when we have PFTs that show restriction, we want to know, is it external or is it an internal disease that makes the lungs small? So when we have restriction pattern in PFTs, we go to the DLCO to see, is it in the lungs? So is there, for example, fibrosis that decreases the DLCO, or is it external? Usually that's a normal DLCO, but it can actually be low, as it was in this instance, if the extrinsic compression of the diaphragm is so severe that it would cause atelectasis in the lung and thus a decreased DLCO. We then learned in the sniff test that the patient indeed had right-sided diaphragmatic paralysis. And so this was like very suggestive for a diaphragm disease. And as we didn't really find any extra diaphragm findings, we were really concerned that this might indeed be like a isolated issue and we won't really find a clue. But then the patient presented a week later with noticeable ocular findings, and then that was the point where we really got our extra diaphragmatic problems, and we ended up with the diagnosis of myasthenia gravis. Yeah, I learned so much. What a fantastic case. Thanks everyone for joining today. See you all soon. Bye-bye.